Welcome to the deep dive. Our mission here is to give you, well, the ultimate shortcut to mastery. We're taking the foundational concepts from a major medical surgical nursing text.
And we are just pulling out the absolute critical knowledge, skills, and attitudes that you need to succeed in practice today.
Right. This isn't just a review session. It's more of a strategic analysis of the material, really.
That's a great way to put it. For this deep dive, we're synthesizing the cornerstone material. The context, the basic operating principles of modern nursing. And if you look at the whole unit we're covering, the theme is just so clear.
What's the through line here?
It's that nurses today are operating in a world that is completely defined by managing chronic illness, disability, and aging populations.
It's not the acute care world of 50 years ago.
Not at all. And that requires a level of critical thinking, of holistic patient empowerment, and interdisciplinary collaboration that is it's miles beyond what was required even a decade ago. So we're here to show you what that actually looks like on the floor.
Okay, let's unpack that right away. Section 1. Core concepts of professional nursing practice. The sheer volume of chronic conditions is it's reshaping the entire context of healthcare.
It is. The system is no longer primarily focused on curing, say, acute infections.
The shift is profound.
It is, and the data really backs this up. The source material points out that nearly half of all U.S. adults are living with at least one diagnosed chronic health condition.
Wow. Nearly half.
And get this, about 60 million people are managing two or more. So when you realize that nurses spend the vast majority of their time caring for patients who are either aging or managing a bunch of chronic conditions or navigating a disability, you see why health promotion is the new focus.
And preventing flare-ups, right? Preventing those exacerbations.
That's the name of the game.
This complexity, it really forces us to rethink what we even mean by health. We still lean on that classic World Health Organization definition.
We do. Health is a state of complete physical, mental, and social well-being. And, the key part of that definition.
Not merely the absence of disease.
Exactly. And that definition is so liberating, especially in chronic care. It means a patient who's dealing with, say, irreversible kidney disease or MS can still strive for and achieve health in those other domains.
The mental and social domains.
Yes. It shifts the goal from this futile chase for a cure to a much more achievable goal of optimization and adaptation.
And that ties right into the idea of wellness, which is more subjective.
Totally subjective.
Yeah.
Wellness isn't just, having a positive attitude. It's a measurable subjective state.
Yeah.
The text defines it as the individual's ability to perform well, to adjust, to adapt to what life throws at them.
And to feel well, to feel harmonious.
That's the core of it.
Yeah.
So our nursing care plans have to aim to promote positive changes toward that person's sense of wellness. It's not a one-size-fits-all thing.
So to make sure we can actually deliver that kind of quality care against this complex backdrop, we use frameworks. And the big one for nursing education and practice has to be the QSEN project.
Oh, absolutely. The Quality and Safety Education for Nurses.
So what's the big idea behind QS? What's it really for?
QSEN was developed to prepare future nurses with the knowledge, skills, and attitudes, the KSAs, that you need to continuously improve the quality and safety of the healthcare systems themselves.
It's like an overarching curriculum guide.
It is. It's built around 6 core competencies. And these aren't just buzzwords you memorize for a test. They are clinical mandates.
Okay, let's list them, and then maybe we can dig into a couple of the trickier ones. They are patient-centered care, interdisciplinary teamwork and collaboration, evidence-based practice,
Or EBP.
EBP, quality improvement, or QI, safety, and informatics. Okay, so if you think about putting these into practice on a busy unit, which of those 6 is often the hardest to really master?
That is a fantastic question. While patient-centered care is sort of the philosophical heart of it all, I would argue that informatics often has the steepest technical learning curve. And interdisciplinary collaboration can be the most challenging culturally, just getting everyone on the same page.
Let's start with informatics then, because we're not just talking about knowing how to chart in the computer system.
Oh, not even close.
Yeah.
Informatics now means you have to understand and use advanced health information technology, HIT, to manage data, to communicate, to support your own decision-making.
So, what are we talking about here? AI?
We are, yeah. We're talking about things like the integration of artificial intelligence into diagnostic support tools. We're talking about the security needs of blockchain for verifiable data exchange and using cloud technology for records that you can access anywhere.
And the big dream here is true interoperability, right? Making sure that the electronic health records can actually talk to each other seamlessly.
That's the dream, and it is so essential for patient safety. I
Hmm.
mean, poor EHR design or a lack of interoperability, that directly clashes with the safety competency.
So how do we guide that?
Well, there's the Tiger Initiative, Technology Informatics Guiding Education Reform.
Tab.
Its whole purpose is to make sure nurses are educated and equipped to use this tech, not just for, clicking boxes, but for real clinical decision support, for reducing errors, and for empowering patients to access and manage their own health data.
So making the tech serve the patient, not the other way around.
You got it.
Okay, so if informatics is the tool, then critical thinking is really the engine that powers all 6 of those competencies. And this gets misunderstood a lot. It's not just making good judgments.
It's not. The source defines it as a very specific, learnable set of characteristics. Critical thinking is a blend. It's logical thinking, sure, but it's also drawing on your past clinical experiences, applying the theoretical knowledge from the textbook.
And that gut feeling.
And that gut feeling, that intuitive thinking that really only comes from experience.
The text highlights a really unique attitude here called bracketing. What does that mean in a clinical setting?
Bracketing is so important. It means you have to deliberately detach your personal beliefs or your assumptions from a patient's situation. So if you really disagree with a patient's lifestyle choices, you have to literally put that judgment in a bracket, set it aside, so you can provide objective, non-prejudicial care.
It sounds like it requires a lot of humility.
It requires immense personal humility. You have to be willing to recognize your own knowledge gaps and be willing to ask for help or input from others.
And on the skills side, we're looking at things like pattern recognition. How does a nurse actually use inductive or deductive reasoning to see a pattern in all the data they're getting?
Okay, think about a post-op patient. You're getting all this data, you see their vitals, BP is dropping a little, heart rate is creeping up, the patient tells you their pain is suddenly worse, and you notice just a little bit more bloody drainage on the dressing.
None of those things alone is a huge red flag.
Exactly. Individually, they're minor. But inductive reasoning lets you cluster that data, the vitals, the pain report, the drainage, and recognize a pattern that's consistent with a hemorrhage, even if it's not dramatic yet. And that moves you to act quickly.
And this whole process, from collecting data to acting on it, is formalized in the nursing process.
Our systematic problem-solving approach, the 5 steps: assessment, diagnosis, planning, implementation, and evaluation.
And we should probably note that the American Nurses Association, the ANA, often slips outcome identification right in there after diagnosis.
Which makes a lot of sense. It forces you to define measurable patient goals right from the start.
Okay, the diagnosis step is where a lot of students get tripped up, especially telling the difference between the 2 main types of problem.
Right. So first you have nursing diagnoses. These focus on the patients or families or communities' human responses to health problems.
Like anxiety or chronic pain.
Exactly. Anxiety, impaired gas exchange, chronic pain, things that are managed primarily by independent nursing interventions, what a nurse can do.
And the other type?
The other type are collaborative problems. These are the physiologic complications that we as nurses monitor for. We're on the lookout to detect if they're starting or if their status is changing.
And the management is different.
That's the crucial distinction. Collaborative problems require both nurse-prescribed and physician-prescribed interventions. So, for example, monitoring for a pulmonary embolus after surgery, that's a collaborative problem.
So the nurse is monitoring for the signs, shortness of breath, anxiety?
Right, and they're administering prescribed oxygen.
Mm-hmm.
But the full management also requires doctor's orders for, diagnostic tests like a CT scan and maybe anticoagulation therapy.
And setting priorities for all of this has to be a team effort with the patient.
A joint effort, always. Guided by urgency, using frameworks like Maslow's hierarchy of needs to figure out what's most important right now.
Okay, that's a solid framework. Let's shift gears to Section 2, professional roles, transitions, and rehabilitation. This is all about keeping care going in what can be a really fragmented system.
Oh, it is. And care coordination is an absolute mandate now. A lot of it driven by cost.
Right. The problem of hospital readmissions.
It's a huge financial and quality burden. The source points out that about 1/3 of all U.S. healthcare spending is on hospitalizations. And rehospitalizations within 30 days of discharge, that affects about 20% of Medicare patients.
And CMS Medicare is now penalizing hospitals for that.
They are actively financially penalizing them. And that pressure is what created this intense focus on transitional care.
So what's the nurse's role in making sure that transition is successful?
Transitional care is all about coordinating consistency as patients move between settings, from the hospital to home, or to a skilled nursing facility or a rehab center. The nurse makes sure medication reconciliation is done right.
Super important.
Critical. They make sure follow-up appointments are scheduled, and, maybe most importantly, they make sure the patient and their family have been educated and actually feel like they can manage the new plan at home.
You're closing the gaps, the communication gaps that lead to people ending up right back in the hospital.
Exactly.
And this demand for coordination has really elevated the role of the clinical nurse leader, the CNL. This isn't just a charge nurse or a manager, is it?
No, not at all. The CNL is a master's prepared nurse generalist who functions as a point-of-care clinician. Their specific job is to integrate evidence-based practice and quality improvement right there on the patient care unit.
So they're like a patient advocate and a systems navigator.
That's a perfect description.
Mhm.
For a specific group of complex patients, they optimize the outcomes and help reduce those really costly readmissions.
Speaking of optimizing outcomes, let's talk about maximizing function. That's the heart of rehabilitation nursing. So how should we be defining rehabilitation?
Rehabilitation is a goal-oriented process. It's centered on restoring or optimizing a person's existing abilities, and the philosophy here is so important. The focus is not on the disability or the impairment itself. It's on the person's remaining capabilities. It's about helping them achieve their maximum level of functional independence.
And to measure that independence, we use standardized tools. The one that always comes up is the CATS Index of Independence in ADLs.
The CAPS index is foundational. It's a quick way to assess a patient's independence across 6 really critical ADLs, activities of daily living.
Right. Bathing, dressing.
Bathing, dressing, toileting, transferring so, getting in and out of a bed or chair continence, and feeding. A high score means more independence.
Are there other tools?
Oh yeah. There's the Functional Independence Measure, or FIMM,
Mm-hmm.
and the Barthel Index. These are all vital for communicating a patient's exact functional level to the whole interdisciplinary rehab team.
Let's get into some specific interventions for mobility and safety. Before you even try to get a patient up, what are you looking for in a mobility assessment?
So when you're moving a patient from lying down to sitting or standing, you have to assess for signs of orthostatic hypotension, that drop in blood pressure. Right. But you also look for other signs of physiological stress, like pallor, so are they pale? Diaphoresis, are they sweating? Nausea, tachycardia, just extreme fatigue. These signs give you immediate feedback about their tolerance for activity and their risk of falling.
For patients who are bedridden for a long time, preventing deformity is a huge concern. We need to know how to use something like a trochanter roll.
The trochanter roll is so simple, but it's so critical. It's just a mechanical wedge, usually a rolled-up bath blanket. You position it to extend from the crest of the ilium, the hip bone, down to the mid-thigh.
And what's it doing?
Its only purpose is to physically prevent the external rotation of the hip joint. If a patient lies on their back for days without support, the hip tends to just roll outward. And that can lead to a permanent deformity that makes walking later on almost impossible.
And along with positioning, there's therapeutic exercises and range of motion, or ROM. We should probably clarify some of those key terms.
Good idea. So abduction is moving a limb away from the midline of the body. Adduction is moving it toward the midline. Think add to the body.
And flexion versus extension.
Flexion is decreasing the angle of a joint, like bending your elbow. Extension is increasing the angle or straightening it.
And what's the most important clinical principle for doing these ROM exercises with the patient?
The crucial rule is this. You move the joint only to the point of resistance, and you must stop at the point of pain. Never push through pain. If you hit a muscle spasm, you just apply gentle, steady pressure to help it relax, and then you can continue slowly to that final point of resistance. But never force it.
When we're helping with transfers, especially after something like a hip replacement, there are some very specific precautions.
Oh, these are non-negotiable. They protect the new joint. There are 3 big rules the patient has to follow.
Okay, what are they?
Number 1, no adduction past the midline, which means no crossing your legs. Number 2, no flexion greater than 90 degrees, so no bending sharply at the hip, which means no low chairs or toilets. And number 3, no internal rotation of the hip.
And nurses use things like abduction pillows to help maintain that alignment in bed. Understanding mobility also means understanding devices like crutches. The text has a chart, chart 2.5, that shows the different gaits. Can you walk us through the practical differences between the main 3?
Let's do it. So we'll start with the most stable one, the 4-point gait. This gives you maximal support. It's slow, but it's safe. The sequence is deliberate, Right crutch, then left foot, then left crutch, then right foot.
Who is that for?
It's for patients who can bear at least some weight on both legs, but need a lot of stability and security.
Okay, then you've got the three-point gait.
Right. The three-point gait is for when one leg is completely non-weight bearing, like after a bad fracture. It's faster, but it requires a lot of arm and shoulder strength because you're lifting your entire body with your arms.
Well, that's a sequence for that one.
You move both crutches and the injured foot forward together, and then you step forward with your good foot.
And the last one is the swing-through gait.
That's the most advanced. It takes the most coordination and upper body strength. The patient puts both crutches forward, lifts both feet off the ground, and literally swings them forward past the crutches.
So that's for someone with really good balance and strength.
Exactly. Maybe someone with impairment in both lower legs. Knowing which gait is right is so important for teaching and for patient safety.
That really sets the stage for how we manage the physical body. So now let's move into section 3, health promotion and patient education. This is all built on the idea of proactively reducing risk.
The focus is definitely on this shift toward wellness, self-care, and risk reduction. It lines up perfectly with national initiatives like Healthy People 2030.
And that initiative really looks at the social determinants of health.
It does. It explicitly recognizes that we have to address factors like poverty, education, and social injustices, because those are often the biggest barriers to people achieving wellness.
The text lists 4 core components of wellness that nurses are supposed to promote.
Right. These are like the pillars of our health education. They are self-responsibility, nutritional awareness, stress reduction and management, and physical fitness. That's the scope of our teaching.
So to design that teaching effectively, we have to understand how people actually change their habits. And that's where the trans-theoretical model comes in, the stages of change.
It's a great model. It outlines 6 progressive stages a person moves through when they're trying to make a big behavior change.
Can you walk us through them, starting with the person who's maybe least ready to change?
Sure. So first is pre-contemplation. The person isn't even thinking about changing. They might not even be aware they have a problem.
Okay, then what?
Then they move to contemplation. Here, they recognize there's a problem and they're thinking about change, but they haven't really committed yet. Next is preparation. Now they've decided to change and they're making specific plans.
Then comes the action.
Right. Action is when the change actually starts. Then maintenance, which is sustaining that change for a while, usually 6 months or more. And finally, termination. That's when the person has no desire to go back to the old behavior and they're confident they can resist a relapse.
And our job is to figure out which stage the patient is in and tailor our approach to that.
Exactly. You can't use an action-oriented strategy on someone in pre-contemplation. It just won't work.
And we know that changing behavior isn't simple. There are a lot of variables.
So many. The text points out 4 main types. There are demographic and disease factors, like your age or how severe your illness is. There are barriers, like lack of access or money. There are resources, like social support.
And then there are perceptual factors.
And that's the critical one, especially the patient's own sense of self-efficacy, their belief in their own ability to actually make the change happen.
Given all this, it's so important to stress that patient education is an independent nursing function. It's written into every state's Nurse Practice Act.
It's a core, non-delegable responsibility. And we need good strategies to actually motivate patients. One method is using learning contracts.
So like a written agreement.
Yeah, a written agreement between the nurse and the patient that outlines specific, measurable goals. Starting with small, achievable goals helps build that self-efficacy we were just talking about.
The material also mentions using mild anxiety as a motivator. That sounds a little tricky.
It is, but it can
Yeah.
work. We're talking about just enough worry about the consequences to spur action, but never so much that it's debilitating or causes panic. It's a fine line.
But none of that motivation matters if the patient can't understand the information. Which brings us to the huge issue of health literacy.
It's an enormous barrier. Low health literacy, just difficulty getting, processing, and understanding basic health information, is directly correlated with poor health outcomes and not following the plan of care.
So our duty is to provide information that's easy to understand.
Culturally appropriate, in plain language, and accessible. You should always assume the patient's literacy level is lower than you think and use the simplest terms possible.
And to make sure that our teaching actually landed, we have to use the gold standard evaluation technique, the teach-back method. Can you describe how that works?
The teach-back method is essential. You have to move past just asking, do you understand? Because the answer is almost always yes.
Right.
Instead, you ask the patient or their caregiver to repeat back in their own words what you just explained, or to show you the skill they just learned.
Can you give an example?
Sure. You might say, okay, I've just explained how to test your blood sugar.
Hmm.
Now, can you show me the steps you'll take to check it when you get home tomorrow morning? And that immediately shows you any gaps in their understanding.
And you can correct it right there on the spot.
Instantly.
And finally, the learning environment itself is key. Not just physical comfort, but also timing.
Timing is everything. You can't teach effectively when the patient is exhausted, in pain, or super anxious about a procedure. Minimize distractions. The goal is just to maximize their ability to focus and absorb the information.
All right, let's move on now to Section 4, Comprehensive Health Assessment. This is where we gather all that baseline data to start the nursing process. It all begins with the health history interview.
And the structure of that interview is very systematic.
Mm-hmm.
You start with biographical data, then the chief complaint, why they're here. You follow that immediately with the present health concern, which is the detailed story of the current problem.
Then you go broader.
Then you get the past health history, surgeries, illnesses, immunizations, then family history, looking for genetic patterns, a really thorough review of systems, where you go head-to-toe asking specific questions. And finally, the patient profile.
And that's where you get the lifestyle and social context.
Exactly. It's what puts all the clinical data into perspective.
When you're interviewing patients, especially older adults, the pace and the environment are just so important. What are the key adaptations we have to make?
You have to be calm and you cannot be rushed. For older adults, make sure the lighting is good but not glaring. Minimize background noise. If they have a hearing impairment, position yourself so they can see your lips and speak clearly, but don't shout.
And no medical jargon.
Absolutely no technical terms.
Hmm.
And you have to summarize and clarify what you're hearing as you go to make sure you've got the story right.
We also have to be ready to get into sensitive topics that are often just skipped over, especially with older adults or those with disabilities, like sexual health.
It's our responsibility to open that door. We have to avoid the assumption that older adults or people with disabilities are asexual. A good way to do it is with a normalizing statement.
Like what?
Like saying, you know, many of my patients who've had a similar diagnosis worry about how it will affect their intimate life. And that provides a gentle opening for a more direct question.
And we also have to be prepared to assess the risk for intimate partner violence, or IPV.
It's a complex and sensitive assessment, but it's essential. IPV affects people in every demographic. And if abuse is suspected or confirmed, the nurse's priority has to be the patient's immediate safety and connecting them to the right community resources.
This whole assessment has to be culturally competent. The goal is moving toward cultural humility, right? Being able to see how a patient's culture affects their care.
Yes, we can use frameworks like Geiger and David Heizar's transcultural assessment model to guide us. It helps us look at 6 cultural phenomena.
For instance,
How does the culture influence communication? Is speech direct or indirect? How do they view personal space? How do they perceive time? Is being on time critical or is waiting expected? And really important things like modesty and who is allowed to be in the room during care.
and the ethical use of all this personal data is paramount.
It's everything. Strict confidentiality and privacy. The patient has to understand exactly why we're asking for this information and how it's going to be used to help them. Transparency is the only way to build trust.
Okay, shifting to the physical part of the exam, we follow a very systematic approach with 4 techniques. Let's walk through the order. Inspection, palpation, percussion, and auscultation.
Right, so inspection is just skillful, deliberate observation. Seeing, smelling, listening before you even touch. Palpation uses touch to feel for things like masses, tenderness, or pulsations. We do light palpation first, then deep.
And percussion.
Percussion is tapping on the body surface to create vibrations that tell you about the density of what's underneath. It helps you figure out organ size and location. And then auscultation.
Listening with the stethoscope.
Right. Listening for bowel sounds, heart murmurs, lung crackles. And there is a critical clinical alert about the order of these techniques, specifically for the abdomen.
Yes, this is a big one. The rule is auscultation must be performed before palpation and percussion when you're examining the abdomen. Why is that so important?
Because if you start poking and tapping on the abdomen, palpating and percussing, you can physically stir things up. You can increase peristalsis, the movement of the bowel.
That messes up your assessment.
Completely. You might artificially stimulate bowel sounds and think they're hyperactive when they're not. Or you could miss a critical problem like a paralytic alias. So you listen first to get the true, unaltered baseline.
Now, we don't always do a full head-to-toe exam. Often we do a focused assessment. What does that look like?
A focused assessment is just tailoring the exam based on the patient's chief complaint. If a patient comes in reporting diplopia, double vision, you don't start with a skin check. You jump right into an intensive neuro and eye exam to address the acute issue,
And intertwined with all of this is the nutritional assessment.
which is so essential for healing and recovery and resisting infection.
What are we looking for?
Well, we look for obvious visual signs of deficiency, like muscle wasting or poor skin integrity. But we also have to assess risk factors, especially for older adults. They're at a higher risk because of polypharmacy.
So medication side effects that reduce appetite?
Right. Also social isolation, frailty, and a big one, poor dental health or dysphagia.
For this high-risk group, we have a validated tool. Can you tell us about the Mini Nutritional Assessment, the MNA?
The MNA is the standard screening tool for older adults. It's simple. It uses criteria like BMI, calf circumference, and questions about recent weight loss or decline in food intake.
And the scoring is straightforward.
Vary. 12 to 14 points is normal. 8 to 11 means you're at risk of malnutrition, and 0 to 7 means you are malnourished. It gives you a clear, objective number to guide your interventions.
Finally, we have to be aware that diet isn't always a choice. There can be cultural and religious prohibitions.
Absolutely. And nurses have to know these. For people practicing Islam, no pork or alcohol. In traditional Judaism, no pork or shellfish, and a strict separation of milk and meat dishes during the same meal.
Which would have huge implications for nutritional supplements, which are often milk-based.
Huge. Being sensitive to this is about respect, but it's also about ensuring adherence to the plan.
Okay, this assessment groundwork leads us right into Section 5, steady state, stress, and the body's responses. We're moving into the physiological mechanics of health now, starting with homeostasis.
Homeostasis, building on Claude Bernard's work, is just the maintenance of a dynamic balance, a steady state. It's happening despite constant changes inside and outside the body. It's not static at all. It's a very active process.
And it's regulated by negative feedback mechanisms. How do those work in practice?
So a negative feedback loop monitors a set point, like body temperature. If your body deviates from that set point, say you get two hot sensors trigger responses that reverse that deviation.
Like sweating.
It's exactly. Sweating and vasodilation to cool you down and get you back to the set point. And the major organs that are constantly working to maintain this steady state are the heart, lungs, kidneys, liver, GI tract, and the skin.
When that steady state gets challenged enough, we get a stress response. So we need to define the stimulus, the stressor, and the condition it creates stress.
A stressor is just the stimulus that triggers the stress response. It can be physical, like an injury. It can be physiologic, like pain or an infection. Or it can be psychosocial, like grief. And we also categorize them by duration.
Acute versus chronic.
Right. Acute, time-limited stress, like a sudden illness, versus chronic, enduring stress, like managing a lifelong disability.
Psychologically, we process stress through something called cognitive appraisal. The text mentions two types.
Yeah. So first is primary appraisal. That's where you evaluate what is at stake. Is this threat a big deal? Then there's secondary appraisal, where you evaluate what can be done. Do I have the coping skills and resources to handle this?
And the ability to function well under that kind of stress is defined as resilience.
It's exactly resilience.
Physiologically, the stress response kicks in fast, integrated by the hypothalamus. What's that initial rapid response?
The immediate reaction is the sympathetic adrenal medullary response, the SAM response. That's our classic fight or flight.
Right.
The sympathetic nervous system stimulates the adrenal medulla to dump catecholamines, epinephrine, and norepinephrine into the bloodstream.
And that causes the heart rate to go up, blood glucose to rise for quick energy.
Yep. It shunts blood to the muscles. It's all designed for rapid, short-term survival.
But if these coping patterns become chronic or they don't work, they become maladaptive responses.
Correct. Maladaptive responses are patterns that don't promote health. Things like chronic overeating, social withdrawal, or that constant hypervigilance that leads to burnout.
Let's talk about what happens at the cellular level when stress becomes overwhelming cellular injury. What are the most common causes?
The most frequent causes are hypoxia, not enough oxygen, direct chemical injury from toxins, and infectious agents. And there's a cascade effect. Inadequate oxygen or nutrition makes the whole system much more vulnerable to infection.
The text also specifically calls out the strain that obesity puts on the body.
It does. I mean, there's the mechanical strain on the joints, but physiologically, the sheer mass of tissue requires a lot more cardiac output and energy just for maintenance. And that chronic demand is why obesity is so strongly linked to chronic inflammation, cardiovascular disease, and a higher risk for many cancers.
When injury does occur, it triggers inflammation. Walk us through how that process starts.
Inflammation is triggered by chemical mediators like histamine and kinins that get released at the site of the injury. These mediators cause immediate vasodilation, the blood vessels open up, and increase permeability.
Letting the white blood cells rush in.
Exactly. Allows white blood cells and fluid to get to the compromised tissue. Systemically, this can cause fever, which is from endogenous pyrogens released by our own immune cells, and leukocytosis, which is just a rapid increase in white blood cell production.
And the final phase is healing. How does the body decide whether to regenerate or replace the damaged tissue?
It happens in one of two ways. Regeneration is when the defect is repaired by making more of the same type of cells that were damaged. This happens in labile cells like skin and stable cells like the liver.
But sometimes the damage is too much for that.
Right. If the damage is too extensive, you get replacement. The defect is filled in with connective tissue, and that results in a scar. Permanent cells, like neurons, generally only heal by replacement, which means you get scar tissue instead of functional brain tissue.
So given all these stressors, our interventions often focus on interrupting that cycle. We mentioned relaxation techniques.
Yes. Things like progressive muscle relaxation or the Benson relaxation response. These are learned, intentional methods you use to consciously interrupt that hypothalamic activity that drives the stress response.
So you're essentially activating the rest and digest system to counter the fight or flight.
That's a perfect way to describe it. You're activating the parasympathetic nervous system to reduce the physical and psychological toll of chronic stress.
Okay, let's move into section 6. Genetics, genomics, and personalized health. This is really the new frontier, and the language can be really confusing, so we have to define the terms clearly.
This is so vital. Genetics is the study of single genes and their effects. So, for example, looking at the single gene that causes sickle cell anemia.
And genomics is broader.
Much broader. Genomics covers all the genes, their interactions with each other, and crucially, their interactions with the environment.
And then there's epigenetics. This is the one that seems to explain how our lifestyle can change how our DNA works.
Exactly. Epigenetics refers to changes in gene expression, how genes get turned on or off, that are not caused by changes to the DNA sequence itself. These changes are often driven by our environment, our diet, stress, our lifestyle.
So two people could have the same genetic risk, but different outcomes based on their life choices.
Precisely. One person's healthy lifestyle suppresses the gene's expression, while the other's poor diet triggers it.
And the ultimate goal of all this science is personalized treatment. That brings us to pharmacogenomics.
Pharmacogenomics is the approach that's set to revolutionize drug therapy. Instead of trial and error, it aims to tailor the right drug, at the right dose, the best safety profile, for a specific patient based on their unique genetic variations.
It should dramatically reduce adverse drug reactions.
That's the hope.
When we look at the basic genetic mechanisms, we often start with problems at the chromosomal level. Let's talk about aneuploidy.
Aneuploidy is just having an abnormal number of chromosomes, either an extra one or missing one. The usual mechanism is non-disjunction. It's the failure of a pair of chromosomes to separate completely during cell division. This is what causes conditions like Down syndrome, which is trisomy 21, 3 copies of chromosome 21 instead of the usual 2.
And then we have gene mutations, which are permanent changes in the DNA sequence.
Right. And while our bodies have amazing repair mechanisms, these changes can alter the structure of the proteins our cells make. Most get repaired, but the accumulation of unrepaired changes over a lifetime is a major factor in complex diseases like cancer and Alzheimer's.
So nurses need a basic understanding of inheritance patterns to explain risk to families. Let's start with autosomal dominant conditions.
An autosomal dominant condition like Huntington disease only requires a mutation on one chromosome in the pair. If one parent has that gene, there is a 50% chance for each child to inherit the disorder.
It tends to show up in every generation.
Typically, yes.
And how is that different from autosomal recessive conditions?
These are different. For a recessive condition like cystic fibrosis, a person needs to inherit the gene mutation from both parents to have the disease. Carriers, who only have one copy of the mutation, are usually asymptomatic.
So if both parents are carriers...
If both parents are asymptomatic carriers, there is a 25% chance with each pregnancy that their child will inherit both copies and have the full-blown condition.
The availability of all this genetic testing creates some pretty profound ethical dilemmas. The text talks about the tension between autonomy and beneficence when it comes to predictive genetic testing, PGT, in children.
This is a huge area of debate. Should we test a child for a late-onset condition like Huntington's that has no treatment right now? Doing so infringes on their future autonomy to decide for themselves.
But the situation changes if there's an early intervention available.
It changes dramatically. For a condition like familial adenomatous polyposis, or FAP, which can lead to colon cancer, early testing allows for life-saving surveillance and surgery. So here, early testing might conflict with the child's future autonomy, but it serves the principle of beneficence acting in their best interest.
Thankfully, we do have some legal protections in place. Tell us about JNA.
The Genetic Information Non-Discrimination Act passed in 2008. It's crucial. It protects healthy people who carry a gene mutation from discrimination in two major areas: employment and health insurance.
So your boss can't fire you and your insurance company can't drop you based on a genetic test result.
That's the idea. It prevents employers from making hiring or firing decisions based on genetic risk, and it prevents health insurers from denying coverage or charging higher premiums based solely on those results.
So with all this complexity, what is the nurse's main role in genetic management?
It starts with the assessment. You have to get a thorough, accurate three-generation family health history. Then it's about assessing the huge psychosocial impact of this information, the fear, the guilt, the anxiety, and making sure you provide appropriate referrals for certified genetic counseling.
This moves us perfectly into Section 7, disability and chronic illness management. We've already established that chronic disease is the new norm.
It is. Chronic diseases account for 7 of the 10 leading causes of death in the U.S. And managing multiple chronic conditions, MCC, is increasingly common and linked to much higher morbidity and just astronomical healthcare costs.
And disabilities themselves are categorized broadly: developmental, sensory, intellectual, physical, acquired.
And we have to recognize that many people age with these conditions, so this is essential knowledge for all nurses.
To guide our interactions, we can look at different philosophical models. The source highlights the interface model of disability. What's special about that one?
What's really notable is that it was developed by a nurse. And this model fundamentally rejects the idea that disability is an abnormal state that needs to be fixed.
So what does the interface model require from a nurse?
It's about empowering the person with the disability, focusing on their capabilities despite any impairment. And it shifts the focus from fixing the person to actively advocating for the removal of societal and structural barriers that limit their function.
So for the bedside nurse, that means helping the patient navigate institutional barriers to get the care they need.
Exactly.
Let's talk about communication, because this is where good intentions can sometimes go wrong. What are the key interaction guidelines?
The rules are simple, but so important. Treat adults as adults. Always speak directly to the person with the disability, not to their caregiver or interpreter. Offer help, but only if they accept it, and then follow their directions on how to help. Don't assume you know what they need.
And don't patronize them.
Never.
On a practical level, we also have to follow the accessibility mandates from the Americans with Disabilities Act, the ADA.
Right. The ADA requires that reasonable accommodations be provided at no cost to the patient. This includes things like qualified sign language interpreters, providing materials in large print, and ensuring exam rooms and equipment are accessible.
Like having accessible weight scales and adjustable height exam tables.
Yes, things that seem small but make a world of difference.
When it comes to specific health risks for this population, we need to be vigilant about secondary complication.
We do. Due to mobility limits or certain medications, people with disabilities have a higher risk for things like osteoporosis. And critically, nurses have to address their sexual health needs and recognize the increased risk of abuse and violence that people with disabilities face.
You mentioned accessible exam rooms. A major clinical takeaway here is the absolute mandate to avoid deferral of care.
This is non-negotiable. A physical or cognitive disability should never, ever be a reason to put off a complete health assessment or routine screening, like a gynecologic exam. The healthcare system has an obligation to provide the staff and equipment needed to deliver that care.
Shifting to chronic illness management, the psychological adjustment is enormous. What are the common reactions?
Patients often go through initial shock, followed by intense anger or grief. Their long-term ability to cope is really affected by how suddenly the illness started, the quality of their family support system, and the sheer uncertainty about the future. That uncertainty is a profound stressor in itself.
So ultimately, the nursing focus is on managing symptoms, avoiding complications, and maintaining the patient's own definition of quality of life.
Yes, and this is where we get back to patient autonomy. The nurse has to respect the patient's choices, even when they make what we might see as unwise choices about their lifestyle or treatment adherence. Our job is to inform and support, not to dictate.
And that ethical tension where a nurse sees a patient making a decision that conflicts with what seems like the best clinical outcome, that can lead to a deep sense of moral conflict.
It does. We call it moral distress.
Can you define that for us?
Moral distress happens when the nurse knows the ethically correct action to take, like supporting a patient's informed refusal of a painful treatment. But they're constrained by institutional rules or a lack of resources or power hierarchies that prevent them from acting on that knowledge.
And that's a direct path to burnout.
A major cause of burnout and attrition in our profession.
Recognizing that complex ethical landscape brings us to our final section, Section 8, Health Issues of the Older Adult. A population that requires incredible expertise. The growth of the 85 and older population is just staggering.
The demographics really dictate our focus. The 85-plus population is projected to more than double by 2040. And there's a really powerful finding in the text about confidence in health.
What's that?
High coping self-efficacy, that belief in your own ability to manage stress and solve problems, is associated with a 92% reduction in the odds of becoming frail or pre-frail in community-dwelling older adults.
Wow. So our role in fostering that confidence through education and support is huge.
It's a primary intervention.
We have to know the normal physiological changes of aging to tell them apart from actual pathology. Let's start with the cardiovascular system.
So normal changes include some mild myocardial hypertrophy, the heart muscle gets a bit thicker, the valves get stiffer, and stroke volume is reduced. The critical nursing implication is that these changes mean older adults often have atypical presentations of heart attacks.
Instead of crushing chest pain.
They might just present with sudden shortness of breath or acute confusion.
In the GI system, we see decreased taste and maybe diminished absorption of some nutrients.
Like iron, calcium, and B12. But the major risk we have to monitor for is dysphagia, difficulty swallowing.
Why is that so dangerous?
Dysphagia is a significant risk factor for life-threatening aspiration pneumonia. Nurses have to be incredibly diligent about assessing swallowing before giving anything by mouth.
Musculoskeletally, the old saying, use it or lose it, is pretty true, isn't it?
It really is. We see a progressive loss of bone density and muscle mass called sarcopenia. This just emphasizes how critical it is to promote weight-bearing exercise and ensure adequate calcium and vitamin D to prevent osteoporosis.
And neurologically.
Nerve conduction slows down. So we advise patients to move more deliberately and allow for a longer response time to maintain their balance. But the absolute most important clinical alert for the neurosystem is this.
Okay.
Acute confusion or delirium is often the first sign of an acute infection, like a UTI or pneumonia. It is not normal aging. It's a red flag.
Let's tackle those cognitive issues head-on, starting with delirium.
Delirium is a medical emergency. It has an acute, fluctuating onset, and it's almost always caused by an underlying, treatable physical problem infection, dehydration, a medication reaction, hypoxia.
And if you don't treat it?
If it's unrecognized and untreated, it can lead to irreversible cognitive damage. It's a diagnosis of exclusion. The immediate nursing priority is to find and treat the underlying physiological cause.
How is that different from Alzheimer's disease?
Alzheimer's is progressive, it's irreversible, and it's degenerative. And it is explicitly not a normal part of aging. The diagnosis is also by exclusion ruling out reversible causes of dementia like depression or vitamin deficiencies.
And the management is different.
Very different. For AD, management involves using cholinesterase inhibitors to try and slow the progression, and most importantly, using nursing interventions to maintain a calm, structured, and predictable environment for the patient.
Nurses often encounter something called a catastrophic reaction in patients with AD. What is that and what do we do?
A catastrophic reaction is a severe emotional overreaction to excessive stimulation or distress. It might look like crying, screaming, or extreme agitation. When this happens, the nurse's priority is to remain calm, use simple distraction techniques, and postpone whatever activity triggered it. Forcing the issue will only make it worse.
The single biggest medication challenge in geriatrics has to be polypharmacy. Why are older adults so vulnerable to adverse drug reactions?
Their vulnerability comes from altered physiology. Specifically, their liver metabolizes drugs more slowly, and their kidneys eliminate them more slowly. This means drugs stay in their system longer and can build up to toxic levels more easily.
So our nursing principles are?
Start low, go slow. Use the lowest possible dose and increase it very slowly. We have to simplify the medication regimen as much as we can and ensure rigorous medication reconciliation at every single transition of care to prevent dangerous interactions or accidental overdoses.
And finally, we have to acknowledge the immense psychosocial and economic burden of caregiving.
Informal caregivers, family, and friends provide billions of unpaid hours of incredibly complex care, and we know this is a predictor of their own physical and mental health problems.
And nurses have a role in helping families navigate housing options.
We do, from aging in place to assisted living to skilled nursing facilities, and it's so important for them to understand that the vast majority of long-term care costs are paid out of pocket. Medicare only covers acute or short-term skilled needs.
And given the vulnerability of this population, we have to be ready to recognize the high risk of elder neglect and abuse.
It's a serious and often underreported risk that happens in both community and facility settings. Nurses are intimately involved in daily care, so we have to be educated and empowered to recognize the signs of physical, emotional, and financial abuse and know our legal and ethical duty to report it.
This entire deep dive has taken us from the specific mechanics of the nursing process and homeostasis all the way through the ethical complexities of managing chronic illness, disability, and advanced age. The common thread seems to be the immense demands placed on the nurse.
That holistic view is absolutely the key takeaway. The nurse's duty is centered on objective, evidence-based assessment and ethical advocacy. Modern practice just demands cultural competence, adaptability, and a real commitment to coordination. We saw that with the CNL role with the interface model of disability.
And especially in those high-stakes decisions facing older adults, which you said can trigger that moral distress.
Exactly.
That feeling of knowing the right thing to do, but being blocked by a system that prioritizes other things, like efficiency or money, over the patient's autonomy.
That example of the nurse who's caught between conflicting family wishes and institutional policy about life-sustaining treatment, it really raises the most profound institutional question for healthcare today.
Okay.
Considering all the advancements in genetics, the complexities of multiple chronic conditions, and the absolute importance of patient autonomy at the end of life, what ethical and structural steps can we take as institutions, beyond just relying on individual nurses to be heroes, to dismantle those power hierarchies and reduce moral distress, so that every nurse feels truly empowered to advocate for their patient's best interest, even when institutional pressures conflict with their conscience?
That is a question for every single healthcare professional to be actively engaged with. Thank you for joining us on this essential deep dive into the foundations of medical surgical nursing.
A warm thank you from the Last Minute Lecture team.